I think, is it 8 or not yet?
Yes, 9:30. Let me start with a brief introduction. I think we started having our audience, and I guess in 2-3 minutes we will have more. Let me give a little introduction. It's at the same time very easy and very difficult to introduce Dr. Chatterjee. Firstly, thank you so much, Dr. Chatterjee, for being with us here. Thank you so much for your time. This is the first talk in the series of expert talks organized by JBSPDF. We can just say that we have one of the best endocrinologists in the world with us, and be done with the introduction. I'll still say a few more words.
I think you've been infected by the American culture very rapidly.
Yes, yes. Instead of doing that, I'll say a few more words. Dr. Chatterjee is a 72 batch JB scholar. He completed his MBBS from Medical College, Bengal. He obtained the first rank in the MBBS exam. He received 7 university medals. He completed his MD in General Medicine in 1984 from the Institute of Postgraduate Medical Education and Research and SSKM Hospital. He specialized in endocrinology. Throughout his career, he has held positions at AIIMS, New Delhi, Wayne State University School of Medicine, Royal Victoria Infirmary, University of Newcastle, etc. His research work at the Royal Victoria Infirmary translated into the development of better treatment options for acromegaly, and the work was published in the Lancet journal. He did the MRCP in the UK in 1989 and obtained the diploma of the National Board India in endocrinology in 1993. He has authored over 40 national and international publications and 8 book chapters. He has published on congenital adrenal hyperplasia, diabetes, thyroid, calcium disorders, and among other topics. Thank you so much, Dr. Chatterjee, for joining. Over to you. I'll also stop presenting so that you can present.
Yes, well, not much to present actually, but what I would really appreciate if the chat box gets populated very rapidly and very quickly and with lots of things, because, or maybe you can even raise your hand, remotely speaking. So something like that would be great.
Should we, just one thing, Dr. Chatterjee, should I read out the questions on the chat box, or you will be following the chat?
No, I can see the chat box.
Thank you.
Let's see. Right. Where are we? Yeah, so am I audible and visible to everybody?
I can hear you properly.
Sure, great. And can you see me? Yeah.
Yep.
Great. So basically, this is, I don't know what to say really, but maybe a sort of a chat would be the most appropriate way of describing what I'm going to do. And a chat, of course, needs another chatty at the other end. So unless you have at least 2 people, you can't have a chat. So I hope the listeners or viewers will bail me out so that we can actually have a chat. Right. So, well, why did I choose medicine? Well, I didn't have any option really, because I just couldn't do any mathematics. Once it came into the imaginary regime, like square root of -1 and so on, I just didn't know how to handle it. I just didn't feel like doing a 3-year BSc course. So all I had left was actually medicine. So anyway, there I was, walked into this medical college, the oldest one at least in Indian, in South Asia, and walked into it in 1974 and walked out of it in 1980, the proud possessor of an MBBS degree. And registration registered under the West Bengal Medical Council. Wow. Well, what did the JBL Institute do for me? It hugely boosted my self-confidence, made me some very good friends who are still there, those who are still alive at least. And I benefited awesomely from the enrichment program. And it was really a surprise to see how easily doors opened for us. I mean, we were welcomed into the Tata Institute of Fundamental Research, as well as into an industrial factory of the Hindustan shipyards, for example. And it was really amazing for me at that age to see how these doors opened. I mean, doors that I never imagined would open, actually. So that was something really, really beneficial. Well, what about college? Now, I assume that a lot of the viewers have had some exposure to medicine. So they will know that most teachers were, I would kindly call them suboptimal. Some were very good. But I quickly realized that it is basically self-study and discussion with peers. That's what keeps one going and helps to acquire the knowledge that is needed. And this requires a huge amount of motivation. The motivation you cannot buy off the street, and it is extremely difficult to generate and sustain the motivation. And I'm sure that is something common to all of you as well. Now, non-motivation, I don't know how that's a good word, but non-motivation is the default mode. Everybody's non-motivated, I would say. But anyway, luckily for me, my motivation revved up during my final years. That saw me coming first, as Arghya has said, in the final MBBS, which was quite not easy because there were more than 1,000 candidates in Calcutta University at that time. And the results, of course, gave me another confidence boost after the JBL Institute. And this boost was pretty good. So that boost propelled me to the MD, to a 2-year fellowship in the US, and to a stint in the Newcastle Medical School. Then back to India. Now, just to share with you some statistics between 1971 and 2021, that's 50 years. 72, there were 15,600 people who passed higher secondary science. That was an 11-year course at that time. The pass rate was 44%. The number of MBBS seats available were 800, roughly. So that was 1 seat for every 20 students passing the HS Science. If you look at MD General Medicine as an example, then there was 1 seat in MD General Medicine for every 33 MBBS pass outs. And at that time, the population of West Bengal was 44 million. 2020, the number of HS pass outs is 245,000. It's gone up by a factor of 15. Just imagine. The pass rate has gone up to 90%. The number of MBBS seats has gone up to 4,000, but that translates into just 1 seat for every 60 students passing HS Science. MD General Medicine, 1 seat for every 58 pass outs. And the population of West Bengal has gone up by hardly 2.5 times. So what has actually happened, that there's a huge number of people who have passed out the class 12 examination in science. Now, some assumptions have been made in this data, but don't worry about that. I think the assumptions, we don't need to discuss that right now. Now, to look at it a little graphically, you can see in 1971 versus 2021, population has gone up in blue. The number of higher secondary science pass outs have dramatically skyrocketed. And the number of MBBS seats, government and private, have also increased, but not to that extent. Now, if you look at the all India situation, there are 54,000 MBBS seats. There are 44,000 postgraduate seats, which is actually not bad, but this is taking everything into consideration, all the postgraduate seats into consideration. And there's something called the Diploma of the National Board. And here we have about 4,000 DNB or Diploma of the National Board seats. A pass rate for MDMS is 90%. I would even say it is close to 100%. Pass rate for DNB varies a lot, roughly 40% currently. But that's not the point. The point is that in MBBS, the pass rate is nearly 100%. The pass rate in MDMS is close to 100%. And if you look at recent Supreme Court judgments, this is what is quoted, that exams are a tyranny where the elite imposes certain rules on the rest and the rest have to comply, etc., etc. So we have crossed all that. Everybody is passing. So exams have become sort of a formality, so to speak, at least in the medical field. But anyway, something has happened. Yeah, I think if you have to, get into medicine, what you have to do is you have to know thyself. This is nothing new. Know thyself is a Greek phrase. I think it was in the oracle at Delphi, then popularized by Socrates, who had to die because of that. Gnoti Suton, that is the Greek. And basically, you have to know what you are. And you have to find out that, yeah, do you enjoy constant study, constant knowledge upgradation, and paradigm shifts? Well, if yes, then you're in the right place. Then you have to find out, are you a clinical type of person or a non-clinical type of person? It doesn't matter what you are, you should know what it is, whether you enjoy, say, a subject like pharmacology better or a subject like, say, surgery better. And this is what you know. This is what you have to find out for yourself. And what about the niche subjects? There, you see, these pass you by very quickly in the medical curriculum, like skin, psychiatry, maybe ophthalmology for some people. But there's no second chance of getting to know these subjects, except as so. And these things actually matter a lot later on, whether you know a little bit of dermatology or a little bit of psychiatry or not, even though your field of work is completely different, because you actually have to treat the whole patient. You cannot just treat one organ or one systems at a time. Now, there is scope for student research. See, there will always be high flyers on the campus. Otherwise, the campus is not viable. If it is a government campus, yes, of course, there will be high flyers. If it is a private campus or a private hospital, these hospitals will not be viable unless there are high flyers driving the hospital. It's like, if you go to a shopping mall, you have a big shop that actually drives the rest of the mall. So something like that happens everywhere. So you need to find these high flyers and try and make somebody a mentor. Not your lifelong mentor, perhaps, but maybe a short-term mentor. And these people, these high flyers, have access to research funds. They often have ongoing research going on. They are often connected with their own professional bodies, which also have access to funds. However, the problem is you can be brushed off. You can be just ignored and said, go away, don't come back, swatted away like a little fly or something. And the reason for that is that we don't know whether we are wasting our time, because you see, you have got near 100% pass in higher secondary. You have got these huge numbers of people passing out. You have got all sorts of medical colleges of all sorts of quality at the moment. So there is no sort of marker by which I can say that, yes, this person is good. If he or she comes to me with a proposal or with something, then it is worth looking at. And that is why brush-offs happen, because we will only find out whether we have gainfully used our time as a mentor or wasted our time until a few months are over. And that is really frustrating. So that is the problem. It's not a problem relevant to you. It's a problem of, I would say, a systemic problem. The ICMR, or Indian Council of Medical Research, offers short-term studentships. These are not difficult to get, but I wouldn't say that these are very important, or it is very important to do research as an undergraduate student, at least in medicine. You really need to learn your craft first, and then there's a lot of time for research later on, provided the basics are already under your belt. Now, exams. Well, of course, you need good marks, that is obvious. The thing about good marks, that if you've got good marks, the faculty in your institute will get to know you better, at least by face. So you know that, yeah, so-and-so has got good marks. So this is the person, this is the name, this is the face this name belongs to. And that is actually quite an useful thing to have. For example, in medical college, when I was there was about 120 students. Now there are 250 students. It's not possible for a teacher to get to know even half of these students. Anyway, and also good marks give you confidence. There's something called honors marks. So this is something like letters in Madhyamik. I don't know what these letters mean, but I have a lot of patients who proudly say that their children have got 1 letter, 2 letters, 3 letters, and so on in Madhyamik, and I just listen to it. I don't think it has got anything to do with your later career, not the letters in Madhyamik, but honors in different subjects. But, you know, as I said, good marks help to personalize your experience. Now, before you get that MBBS degree and you can have a registration number and can actually write a prescription, you have to go through 1 year of internship. Again, I cannot emphasize too much that, you know, learn the niche subjects and then listen to patients. Patients come from all sorts of backgrounds, and in a medical college, hospital, a lot of them will be coming from disadvantaged backgrounds, and their symptoms are very vague. Like, you know, there are lots of, you know, in Bengali, you can say, they can say, Jay, I don't have batha, but I have a jantrana. I don't know what that means. Then they can feel dizzy, which is described as chakkar in Hindi. Then you can have something, the common disease which a lot of people in Eastern India suffer, and that is gastric or gastrointestinal symptoms, commonly described as gas or ombol. And sometimes they're very baffling symptoms, and they're very baffling ways in which they are expressed. The trick is, after you get to listen to them over and over again, is to put it in medical language. And that's very difficult. It's something that really, really has to be learned. And then after you have put it in medical language, assuming you have done it reasonably correctly, then you have to see how much of your theoretical knowledge can be deployed in that particular medical situation after you have got the symptoms into medicalese. So that's something that you have to learn. And this is a very long learning curve. After internship, the next hurdle is the NEET PG. And this is what is guarding the doors to a postgraduate qualification. As I showed in an earlier slide, most people who graduate can aspire to a postgraduate qualification. There are enough of them available. But this sort of chancy affair that NEET is, should really, what should I say, not be applicable in your case. What you have to do, you have to decide what is your broad subject of interest, and also what you do not want to do. And don't get into something you don't want to do, or you've decided just because it's going in a good place. Don't do that, because you're stuck with it for the rest of your life. Move to a lesser rated facility if that is feasible for a field of your choice. Because remember, in your professional life, that's what you're going to be doing for a long, long time. Now, supposing you don't want to do all this, then what? Well, lots of doctors have made it in other fields. The first president of Nepal was a graduate of my college. President of Bangladesh, albeit for a brief time, was a well-known physician of that country. And of course, on the left, on the right, you have Dr. Bidhan Rai. You have Paula Sen in the music field. Arghya Mukherjee is a graduate of Bardhaman Medical College, the son of a very good friend of mine, who has made a very good name in Bollywood. Dr. Mike is an internet sensation whom I didn't know about till my son pointed it out to me. And he's all over the place, I now find. So that's Dr. Mike, and there are lots of Drs. Mike all over. Then at the bottom, you have a stamp with Monopul, Balaichand Mukherjee, Mukhopadhyay. Sorry. And then you have Somerset Maugham, another very well-known physician who actually never practiced. So if you want to opt out, a lot of very, very famous people have done so before you, and a lot of people will do so after you. So don't despair. And there are a lot of, what should I say, negative things about doctors, particularly when it comes to public policy or when it comes to politics. So let us see what is being said here. So what others think of us? This is published in the Journal of the American Medical Association in 1899. So the editorialist says the doctor is a political nonentity. The few that are engaged in politics are really not pursuing the practice of medicine. The rank and file of physicians are not concerned. And there are doctors who believe that medicine and politics are incompatible and consider politics so corrupt that no honest man can have anything to do with it. So it's amazing. This was written in 1899 in the US. Right, let's change gears. Now, assuming that you are in a postgraduate course, as I said, pass rates are so high that your physical presence is sufficient to give you the degree. Now, my own opinion is that you should put in at least the effort that is at least 2 log scales higher than what is necessary to pass. Because this is what you're going to do, and you have to do it as best as you possibly can. In a lot of the degree courses like MD or MS, you have to do a dissertation. It was originally called a thesis, but because of the copy-paste nature of the process, it's now a dissertation. But still, you learn how to handle a reference, you learn how to look up literature, you learn how to write an introduction maybe, or maybe a review of literature and so on. But basically, do ensure that your dissertation is something original. It's not difficult to do, and make it a publishable piece of work and get it published. That's also not difficult. You just have to do something that others are not doing. That's all. But the others, I mean, if you put others within inverted commas, then it is very easy to get a dissertation off the shelf, just change a few things here and there. And dissertations are not physical anymore, at least in West Bengal. You send it over in a pen drive, and 9 cases out of 10, it will be accepted. Now, well, I was in 9.9 cases out of 10. 1 or 2 funny things happen, which if I have some time, I'll share with you. But do psych yourself. You see, this mental psyching is very important, as it is important in every field. In sports, you know, these sports psychologists are very, very important for getting a mindset right. And you will not be, even if you won't be somebody like Nadal or a Ronaldo, unless you really believe in yourself. Believe in yourself that you're a great doctor, you have a great future, and these are just stepping stones to sort of making it possible. The problem is you're getting old, and the biological clock is ticking. And if you are a woman, this is much more relevant, this biological clock issue, and you cannot disregard it. The demands on you are the service demands. You have to do, whatever field you are doing a postgraduate in, you will have to do some service. If it is, say, even anatomy, you'll have to teach anatomy to undergraduate students. If it is surgery, you will have to do surgery or at least assist in surgery on surgical patients, and so on. Learning goes on and on. Might have to do some teaching, which is good, I think. Research, of course, that is your dissertation would be the best thing to take off from. And I would say you should really figure out what life is like in a top international institution, because unless you know what are the requirements in this day and age of a physician of a peer, say, in a top medical school in the US, then I think you're missing out on something. You don't have to copy that, but you should know basically whatever you can understand or whatever you can grasp sitting in India. I think something is better than nothing, but that attempt should be there, or the wish should be there, or the aspiration should be there. And what do we want? Just don't want a little degree after your name, little letters, or an alphabet soup that some people have as well. You want a good quality of life. You want to be an excellent physician. You want to be a well-known teacher, a renowned researcher, and of course, you want to be rich. Now, all these things can't happen together, but at least you can't tick all the boxes. So, well, even if you tick all the boxes, they won't happen. But these are basically the issues that you need to engage with. And you have to realize what is not taught, unfortunately, and what is extremely important. One is statistics. Even today, we have this ridiculous situation of MD students, after having done their dissertation, going around asking a most irritating question: please find me the p-value. And this is guaranteed to give anybody apoplectic fit. So do learn what statistics is about, and think like a statistician, at least when you're doing statistics. Ethics, absolutely untaught. Communication skills, doctors are hopeless in communicating. This is worldwide. And even today in my office, after I have seen the patient and hopefully explained things well to the patient will go outside, talk to my receptionist, again get everything explained. That if there is a blood to be taken, they'll go down to the laboratory and again ask everything to be explained, and so on. And this is very common. And partly this is human nature, but partly I think our communication skills are not good. And this is not taught anywhere actually very well. You need to know a bit of the law as applicable to patient care. And there are a lot of issues here, including consent. And if a patient wants to leave the hospital against your advice and so on. Law is applicable to research. And this is extremely important because these things you don't want to learn the hard way, you want to learn it prospectively. And law as applicable to interpersonal relations. And this is again important, as you know, that there are, in every institution, there are these committees which look at discrimination and which look at gender discrimination. There are different names in different places, but basically anything you say can be something that you will regret, even though you didn't mean what you said at that time. And there are a lot of ways you can get into serious trouble if you're not very, very careful about interpersonal interactions. Behavior towards pharma. Pharma is not a big bad guy. Without pharma or the pharma industry, I think medicine and medical research would grind to a halt. The relationship with pharma industry and with physicians and the pharma industry is extremely complex, and it's extremely layered. And there are a lot of things where we need industry support. And there are a lot of situations where industry needs our support. And there is a gray zone, and then there is a black and white zone. So make sure what is the black part and not get into it. So these things can come and haunt you. And if you look, there are situations in the US, for example, a Supreme Court judge, while he was being nominated in the US, what he said or did when he was 18 years old came up for comment. And you never know what can happen in today's digital age. And you should know a little bit about financials and tax matters. And it doesn't matter, that you are an MBBS student or an MD student or whatever. I think one should have some idea about financials. And tax issues are not that difficult, but basic understanding is necessary. No matter, it's never too early to get the hang of the thing. For example, I'll just give an example. Today, I have to keep a daily book. That means every income tax authorities want that every single patient I see in my office, even if it is a relative, even if it is a colleague whom I see on a complimentary basis, I have to keep a record. This is part of the Income Tax Act. Anyway, so I think these are things, these non-taught things are extremely important. Now, what about foreign shows? Now, one thing I will tell you is that the way systems work in the US is without parallel. There are systems for everything. So even there are systems to guide an illiterate basketball champion into doing things that he would not be able to do without the system working for him. Merit is very much recognized and nurtured at the entry level. You can be sure that it won't be the only factor at higher levels, but at the entry level, it is definitely recognized and nurtured. Now, in the US, money talks the loudest, and sometimes that's the only thing that talks. So you as an outsider physician will be nudged into a non-procedure field. For example, a field like rheumatology or infectious disease or endocrinology. Why? Because if you stay on in the US, whether you do a procedure or not, your income will vary a lot depending on that. By even a factor of 3, you will earn 3 times more than a family practitioner if you are an orthopedic surgeon. So you will find that the system will nudge you towards a non-procedure field. And if it is a procedure field, your training will be elongated so that your lifetime earnings are not as high as that of a local person. So this is fact of life. There is nothing, there's nothing good or bad about it. That's the way it is. The UK, as the other country I have experience of, is much easier to get in and much easier to get out of. There's a huge difference in training in a medical school and in the other hospitals all over the country, which are basically called district hospitals or district general hospitals. The salary is relatively less. And over the last, say, even 15, 20 years, the salary has gone up only according to the inflation, nothing more than that. Quality of life is perhaps better. If you have children, you don't have to worry that the children will be involved in a shootout in school, which you might have to worry about if your child goes to a public school in the US. And one other thing I can say, because you know my age by now, you can guess my age. So I can tell you retirement is not fun in a foreign country. And post-retirement, you will probably live for about between 20 and 30 years. And this is not fun in a foreign country, because the only people you will really have contact with will be the people who have immigrated with you. Doesn't sound very nice, but that's the way it is. What about work in India? Working conditions are certainly not as pleasant as in a Western setting. All of us can do some amount of teaching, training, and research. No matter what you do or where you are, you can do all three of these things depending on what you want to do. If you're really interested in research, make sure that you have security of tenure, that your job is not transferable. Otherwise, it's a huge, huge frustration. And I can tell you that if you're in clinical practice, that means you're doing, say, something like, say, ENT or endocrinology or whatever, and you're near the top in your field, your income will actually match Western incomes. This doesn't sound realistic, but it is actually a fact. And your disposable income is much higher because you're spending much less on your overheads, like your office or your office staff and so on, or even on your children's education. Now, government versus private. Government will give you security, opportunity for teaching, examining, being on committees that help decide policy. The income ceiling is low, freedom of choice is limited, and there are excellent research opportunities if you have a stable job, stable posting. In the private sector, you have to understand the corporates and their behavior and use it to your advantage. There is a lot of freedom of choice. If you don't want to go to work on a Monday morning, you can jolly well sit at home and watch Netflix. You don't have to answer anybody. Income is excellent. There is poor security. If you're ill, you're ill. You don't earn. If you're ill, if you go on a holiday, you don't earn, and so on. Retirement benefits, you have to plan. There are no built-in retirement benefits. So these are issues. So anyway, I think this is basically what I wanted to say. Now, I would really like to hear from the audience, or if you are, there are quite a few of us already plugged in. So if there is anything you wish to say or put in the chat box, I think that would be great. Otherwise, it's not interactive. So let's see.
Yes, please, scholars. This chat is meant to be an interactive chat. That is supposed to be the format. So please ask your questions. This is also your chance to use Dr. Chatterjee's time. I think we have a question, Dr. Chatterjee, in the chat.
The question is gynecology and obstetrics. Is it in demand? Yes, it is in demand, because what should I say? You will have to I mean, it's part of life that, even if you go through some normal things like pregnancy, you will still need the help of a doctor. That's the only field where you need the help of a doctor for, normal activities like pregnancy. And the thing is that you have to decide how much you will concentrate on obstetrics and how much you will concentrate on gynecology. The reason is that obstetrics is good in the beginning, but as you grow older, it is wiser to change to gynecology because odd hours and odd demands on impractical demands of your time are part of obstetrics. And I think that would be better left to younger colleagues. But in the beginning, that's the easiest thing to do. It is in demand. It will always be in demand. And you have to, again, choose exactly the case mix that you will handle. And of course, you will have to decide the type of skills that you acquire, skill mix that you acquire. There's a question that lab over MD. Well, lab was started during the Janata government in the late 70s, when before that our MBBS degrees were considered equivalent to British degrees. But from that time on, they wanted to say, the British General Medical Council said, no, this is not going to happen because the standards are not very good in India, and everybody has to go through a screening exam, which they call lab. Lab pass rates vary a lot, and a lot depends on what is the demand in the UK at that time, I think. And it shouldn't be a difficult exam to pass. However, it has got nothing to do with MD. MD is a postgraduate qualification, and lab is just saying that your MBBS knowledge is equivalent to the MBBS knowledge of a British graduate. That's all. MD is a degree, shows that you are a postgraduate in whatever field you've done your MD in. Avenues for research in Europe. Well, Scandinavian countries are excellent and open doors and very good English knowledge, which is, I think, very important actually for somebody from India. And all getting into the UK is also not at all difficult, because now after Brexit, there is a pretty big dearth of, what should I say, physicians in many fields. And to the extent that two of my junior colleagues in Kolkata have just left and gone, taken up consultant jobs in the UK. I received phone calls saying that, would you come over for a 5-year contract at a huge sum with a university appointment? And if I can't come, can I send somebody? Can I recommend somebody? So there is a dearth, there's no doubt. In UK, it is not difficult. Scandinavian countries, it's not difficult. But where English is not, maybe also in Holland or Belgium, but that I'm not very sure about that. However, if you want to do, I think you have to basically publish papers and have engaged certain rheumatologists in one-to-one conversations. That's very easy to do, but it has to be done on a scientific basis so that you are having a conversation among equals, not just I want to go and give my service. So they have to, take you seriously, because as I said, if your MD pass rate is 100% or close to that, you have to do something that will encourage people to take you seriously.
Dr.
If you study
sorry, I have a question on this line. So Europe is like linguistically very diverse, right? Like it's not like exactly the same in US. If you know English, or if you prefer to say Spanish, which I don't think that's that much popular in Indians, but you will be accepted in most of the cases. And that will be kind of necessary, particularly for medical practitioners. it is very important to say language of that region, isn't it? In that
Absolutely.
case, if you go to France or countries like that, as you spoke, one or two countries like Belgium, Netherlands, how important and how difficult is going to be the language barrier?
Well, if you do research, it is not that difficult. But if you want to see patients, of course, it is going to be extremely difficult. In fact, here there is if you go and study your MBBS in a place where you do not understand the language, I think you are at a perpetual disadvantage, because the nuances of language are so very important in treating a patient. So I think I wouldn't advise it unless you are familiar with the language and even the cultural basis of that. For example, I wouldn't say you go and do rheumatology in France. It's not going to work. In the US, you see, your degrees don't count. They expect you to start from the bottom or as close to the bottom as possible. They might give you rapid uplifts as far as the system allows, but they expect you to start from the bottom. I was an exception in that I didn't have to do a residency in the US. They accepted me into a fellowship straight away. But generally, you will have to start at the bottom in the. So if you have a DM degree, which means MBBS, MD, and then DM, then doing clinical work in the US, first of all, you need to pass the exam, USMLE. Otherwise, you are an observer. You can just look over other people's shoulders. But that is not very easy, passing the USMLE, because you have to do all the MBBS subjects in one shot, and the clinical part is not very easy. You have to go there and do it. Anyway, there's a question from Annesha. So if you study abroad and come back to India, do you face any issues with your clinical practice here? Well, study means basically, I understand that you've done your MBBS in India and then gone at some point after that. I think if you have done your MBBS well, you've understood how people talk and behave and so on, you will not find any issues in your clinical practice. And in fact, you will find it much easier, because by then you will have already learned how to go by protocols, how to go by algorithms, how to have a standard workup for all patients, no matter what, and not pick and choose, which is something that happens here a lot. And you will find that ultimately you will benefit, because patients will benefit if you have an approach of that type. And now, of course, with artificial intelligence, things are changing even more. And I think if you're not familiar with artificial intelligence, you're going to get into deep trouble in a few years' time. Anyway, there's a question that after my postgraduate, sorry?
Yeah, so I'm Dr. Niladri. I actually had asked rheumatology question about the scope in Europe, actually, just before that. Sorry for interrupting, sir. And also say about the artificial intelligence thing, sir, something that really, but then what are could you recommend some good courses that could be helpful in the learning it from the basic? Because I have done my MD from SSKM medicine, so I passed this year, but the amount of scope that we have in about the artificial intelligence and all these latest stuff is actually pretty limited. So
it is very limited.
Yeah,
for example,
so
I just
would
give
be
you.
really
No,
pardon, sir.
Let me tell you right now. First of all, my own idea is that the world will be divided into two types of people: a small minority who will actually program for artificial intelligence, which basically means collecting a huge amount of data and getting the data right and getting it into a computer. And then what happens is that the computer will outperform humans every single time. And there are things that it's already doing right now. For example, if you take a photograph of the retina, that is a fundus photograph, artificial intelligence programs right now, today, can actually tell you whether you have diabetic retinopathy or not in an instant. You can get it done in some supermarkets in the US for $35 or something like that, payable by Medicare also. And so, and that is instant. And this is very, very well documented already. Then there is something called a pap smear, where a swab is taken from the woman's cervix, and it is read on a slide, the swab, to see whether there is any evidence of early cancer. This is done by artificial intelligence much more accurately than humans. MRI scans of the head can be read much more accurately by artificial intelligence than by humans. In India right now, there is no legal framework for this. For example, if artificial intelligence gets it wrong, because it's not been programmed to understand something. For example, if you have a diabetic patient who has a tumor in the retina, which is very rare, and the artificial intelligence has not been programmed to recognize that tumor, it will pass it as normal. And the legal liabilities, etc., have not been worked out at all in India. I'll just give an example from telemedicine. Till the pandemic, telemedicine was banned in India. Telemedicine was very bad. Telemedicine could not be done. And there were very, very strict prohibitions from the NMC and the MCI that you could not do telemedicine. And then after the pandemic, everything changed. Telemedicine was very welcome. Telemedicine was accepted. And the government has come up with a plan that anybody can do telemedicine, with one little bureaucratic provision, that the National Medical Council will start a telemedicine teaching course. And as and when it starts the teaching course, which it hasn't yet done, you will have to pass that course before you can do telemedicine. And now telemedicine is fine because it has got a framework, and I'm doing, and a lot of my colleagues are doing telemedicine. So anyway, so what I'm saying is that AI, and AI, the other part of AI is that, you have to understand that it can go beyond what it has been taught to do. A computer can do something more than what you have actually programmed it to do, and that is already happening. And this field is something that I think wherever you can learn about it, do so. And because this is really an exploding field, and I think in medicine, we've been left far behind. Now, there's a question about USMLE or PLAB. Should I opt for PLAB or USMLE right after my MBBS? Well, right after your internship, yes. It depends, basically, because you can easily do both, because it's the same type of learning that is necessary for both. And in both situations, you will have to leave India to get to do the exams. And so you have to have some plan in mind. And as I said, that in the US, it is easy to get in if you have passed the USMLE, but you will not be given, you will find it difficult to get into a line which ultimately translates into a high income. For example, believe it or not, dermatology is a line which has a very high income, because almost every single patient has a skin biopsy, which is a procedure. There are no emergencies and there are no orders and so on. And you will not find a single first-generation Indian who is a dermatologist in the US. Those are not really slots that an immigrant can get. However, if you look at, say, a field like infectious disease, it's heavily populated by immigrants, and a lot of it from Middle East. So anyway, so I think these are individual choices. If you get everything done, keep your options open till the last possible moment. But it requires travel, and of course you have to have enough knowledge inside you so that you have a good chance of cracking the exam. No point coming back empty-handed, really. Can you please suggest the postgraduate courses currently in high demand for India? This is something very difficult to answer, because it is really what you feel you want to do. If you want to do something that doesn't have a high demand and you're good at it, you will create your own demand. But at least you will be spending your professional life doing something you enjoy. For example, I'll give an example. Say ophthalmology is a pretty high-paying, high-income specialty. Now, you may not like to do ophthalmology. So just because it is a high income or a high demand field, just don't go into it. Go into something that you enjoy. And if you enjoy something that is high demand, that is great. But I think what you want to do is more important than, that's my own feeling. But I can definitely tell you that every field you can do, again, chart out your own course. You can do as much of teaching, training, research, or actual patient care as you wish to do. And so that freedom of choice exists all through. So
payment option as well.
We have a question. If we opt for surgery, should we go for MRCS or MS? See, I personally feel that surgery is not about cutting at the MS stage. At the MS stage, you must know how to take a history, how to examine the patient, take a decision whether the patient needs surgery or not. You can actually leave the surgery to someone more experienced and just watch. But you must know what are the complications. You must know how to handle or recognize a complication. So if this basic knowledge is there, then I think going to the next stage where you are actually doing the surgery is much easier. But if you've done, so you might actually end up doing maybe, say, 10 gallbladder surgeries, but if it is in a good setting where you have learned all these other things, you will be a much better surgeon than you've gone to a small hospital and have done, say, maybe 100 cholecystectomies or gallbladder surgeries without really understanding what you're doing, or without being able to recognize or anticipate or treat a complication. So I think this learning part is very important. MRCS requires, not always, because you can bypass the PLAB if you are recommended and get into a collaborative program. Again, the qualification is not the thing. The thing is really getting to know how to do the work. And after that, you see, after the MRCS, which is in the UK considered an entry-level exam, which means it is like getting into MD or MS. Same for the MRCP and the MRCOG. They're considered entry-level exams. Because of our colonial heritage, we consider them to be higher degrees, higher diplomas, I would say, because they're not awarded by university, higher diplomas than the MS or MDs over here. But they are entry level. So after that, the training you get, where you get, how you have been trained is much more important. But here, our colonial structure says that, MRCS is, that means you're already a good doctor, whereas in the UK system, you are just a doctor who has been selected as appropriate for further training. So anyway, so these are, I think what I would say is that if you know the subjects and know what, and you have the privilege or the good fortune of doing something you enjoy doing, I think 80% of the battle is over. And that is actually the best thing. Yeah.
Sudipda Paromita here. Good evening.
Good evening.
Sudipda, I get to meet a lot of scholars. And apart from the JBNSK scholars, because I'm a psychologist, I meet a lot of people, students who are either aspiring for medicine or they have just got into medicine, but their interest, original interest, even though their original interest was not medicine, I have a small group of people who have got into medicine because of other pressures. And many of them are doing well in medicine. It's not that they are not, but their mind is not into it. And they are sort of waiting for the time that they can finish. And in their moments of frustration, when they come to me, they even go on to say that I don't want to practice medicine. I want to do something else with myself. So I'm coming back to what Niladri was saying and what you eventually said about this AI platform to develop your skills. So that could be a very good that could be a very good career for a doctor who is not interested in practicing, but who can help the medical community by developing AI. Because I have a lot of students who have interest in electronics, physics, but are actually studying medicine, and
Yes.
they want to do something with that. So this was a real learning that they could do something like this and still be connected.
No, I fully agree with you, Paramita, because I will tell you, I mean, in our time, this was not the case. But now, I mean, my wife is actually a professor in SSK, and she actually took a poll of her students. She teaches pharmacology there. So she took a poll, and to her surprise, about 60% of the class said that medicine was not our choice. We've been sort of railroaded into medicine.
Yes, Sudip, yes. And it's a
And,
very big problem.
No, this is a fact, and this is very unfortunate because particularly, I think physician parents are very guilty of this. And I think this is very sad because, and the commonest response was what, and then, my wife asked her, what would you have liked to have done? The commonest response is that you would have liked to do physics.
Yes.
There are some outliers. The one that said, I want to be a model and I want to be I want to
study history. I have found
yes.
quite a few who say that I just wanted to study history.
This is very unfortunate. This is very unfortunate.
So AI seems to be a very good idea. And so medical statistics also seems to be a very good idea, because for students who still aspire to study maths and who are interested in maths and statistics, this may be a good...
Medical statistics is no different from any other statistics, really. It's just
right.
that, it is deployed in this particular field. And I think AI is going to explode. I mean, not only in medicine, it just needs a robust medical legal framework. Without that, for example, as I give an example, I mean, if the AI makes a mistake, who is responsible? Supposing you go somewhere, AI says you've got a problem and you don't have a problem, or AI clears you and you ultimately turn out to have a problem. Well, it depends. It actually depends on how what the programmer has done. But then who is responsible, and how is that responsibility going to be shared, allocated? Who is going to take the blame? Or nobody should take the blame. I think it's an unfortunate thing that happens that, for example, so many unfortunate things have happened in the history of, say, cardiac surgery, or say in the field of aviation, where a lot of people have died before, things have improved.
No, but you're right. A medical legal decision protocol has to be fixed.
It's actually what it will happen. It will happen. It's just that
eventually
there is not a critical demand for it yet. And the other thing is, of course, the environment. The environment is going to impact us in ways that we cannot even imagine right now. And it's not just, I have so many friends who come from the US and say, Calcutta is so polluted. It's true. It's polluted with suspended particles. But if you look at carcinogens in the very clean water of the US or the UK or wherever, or Europe, if you look at the carcinogens present in the water or in the soil because of the longer history of industrialization, you will find that the incidence of carcinoma of various types is far higher in these countries, in the US or in Europe, than in India. And this is not because Indians are dying early. It is because of the carcinogens present due to the long industrial activity in these countries. Even though you have clean water, clear looking water, it is not completely harmless water. This is data that is there. I mean, you can just look it up.
Thank you very much.
I have a quick question. Sorry, Paramita.
Just 1 minute.
Yeah, sure. Go ahead.
So, Sudipta, has your wife, Dr. Mrs. Chatterjee, has she published that paper on that?
No.
That study?
It was just a sort of a straw poll. It was not a paper. It was, but then she found
I would have liked to read it. Yes.
Is there any way to create interest? This is really a tough question. I have no idea how this is to be done, but I can tell you that, you have to believe in yourself. You have to realize you're a great person with a great future, and you're just going to get into that very, very soon. That will become a reality very soon. And don't forget that. I got an interesting question. Why did you choose endocrinology? Well, first of all, when I was finishing my MD, I found that endocrinology was very poorly represented in Eastern India. So I thought it would be a subject, which would be easy to see patients, because there weren't very many in that specialty. Secondly, it was a non-procedural line in the US. So it was easy to get into a fellowship, relatively easy to get into a fellowship there. Third, I always felt that I could give what should I say, completely vertical service, like looking at the patient, then also doing the endocrine tests on the patient. And that actually is something I've been fortunate enough to do. And that completely, that the patient has a completely, what should I say, vertical experience with me or with my clinic. I think something that I had planned and that ultimately has become a reality. In some countries, this would be construed a conflict of interest, that I am treating the patient and I am asking the patient to get some, not asking, but I'm saying that you can get the tests done in my laboratory or the laboratory I supervise. But here patients feel that gives them an extra level of security and safety. So I had this in mind, all these things in mind when I chose endocrinology. The other things I was thinking about was rheumatology, again, very similar situation, and nephrology, there again, very similar situation. But the nephrology patients I saw were a little depressing. So I thought I scratched out nephrology from my list, but rheumatology was a pretty close second to endocrinology. But ultimately it was, I think, where I got my fellowship opportunities, or where I got my opportunity to work in AIIMS Delhi, actually, for 6 months or so. Anyway, so those are, I think, chance also plays a huge role in your life, I think. And this is one of those things.
Did we answer this question, Dr. Chatterjee, that team 3, the question, I don't see a proper name. So basically the question is that, after getting my postgraduate degree, can I opt for US MLE or PLAB? Or should I opt for these degrees after my MBBS?
No, these are not degrees. These are just sort of, it's like a visa. It's like you have a visa on your passport to get into the US. So this is a visa to get into the medical field into the US.
My bad. I made that mistake while reading the question. He did not say these are degrees.
So both these exams are basically a condensed version of the entire MBBS course as taught in these countries. And you have to clear that in several stages. And then the system will consider you equivalent to their local graduates. There's a question. So I think if you have that knowledge, the same knowledge will get you a pass in both. If you have the knowledge, if you have the resources to go to the centers where the exam is administered, and in the UK, of course, lab is only in the UK, where it is administered, then that's it. I think the same knowledge can get you into both, and then you can keep your options open depending on how things pan out in your life subsequently. Now, how do you get into research after MBBS or MD? I think there's no point getting into research after MBBS, because if you have a research bent of mind, then I think you need at least another qualification before you can do serious research, or if you do research that people will take you seriously. If you're going to work in India, I think with an MBBS, it is very difficult to get to the top levels in research institutes in India. So and there is a provision for getting a PhD after MBBS, but I think it would be much more logical to get a postgraduate qualification in some field of your choice. And after that, you can, if you wish to get into research straight away, there are, ICMR has a lot of institutes. There are a lot of institutes like the different AIMSs that have come up, where if you get in, you stay there forever. So there you can build up a research lab and a research career. But if you're in a place, if you're in a private institution, then I think unless, you know, that institution has a reputation for nurturing research, I think it's a bit, what should I say, insecure. And if you're in a job that can be, that is transferable, then I think you shouldn't be doing research, because there's nothing more frustrating than being transferred after, you know, halfway through your research project.
Sorry, can we, sorry, you, were you saying,
No, no.
saying something?
No, I'm not saying anything. Please.
Can we bring us back to Dr. Niladri Bhaumik's question once more? I wanted to ask this. The question was like, what is the role of AI in general and in a vast level? And we discussed about it at a length. I have some specific questions here. Those of us from maths and computer science background, and maybe doing PhDs, particularly in, I exactly do not know the research facilities in India, but I have seen here that the medical research that happens in an environment where doctors are there and statisticians, like, you know, from computer science or maths or statistics departments, they are working collaboratively. And that's how the medical research plus AI that is going on. Does it happen like the same way in India? Does, particularly the question is like, do doctors take part in this research? And if they don't, like for studying the introductory things about, you know, going in this way of AI, there are so many courses present online in websites such as Coursera, edX, and blah, blah. Is like, do you suggest those courses, or do you have some other courses in mind, so that, you know, particularly, I guess what he was asking, like, can we name some resources there as introductory courses that we can just find online and go about it?
There is no end to the research. You see, AI and machine learning are slightly different. And I think the resources available are enormous. And our level, our baseline level is abysmally low. So I think you have to build up your knowledge of the field. I mean, I'm talking about to the audience. Build up your knowledge and it can be, it's a very personal thing, because, you know, you can find something on the net that interests you. You can come across a paper that interests you. You can talk to somebody if you like, and you gradually build up a basic knowledge of AI as it exists today. And then after that, you see, I really don't think I'm very qualified to say what happens after that. But I can tell you this, that what I have learned about AI is simply mind-boggling. And I cannot wait to see how this AI will be translated into day-to-day patient care. The issue is that you need a lot of data, a lot of input, and a lot of outcome data. Because, for example, if you just take an MRI scan, the computer has to be programmed with, say, 10,000 MRI scans. I'm just giving a figure, not just 100 MRI scans. And then the scans have, say, a problem in different shades of gray, very subtle differences between them. and the program is taught that difference number one means this, or me mean this, difference two means something else, and so on. But that huge amount of data to be accumulated and the outcome data to be accumulated, only after that can you actually write medically relevant AI program. Now, this is not happening in India, that's for sure. We just don't have that kind of outcome
sir,
data. Yes,
after
sir?
being 3 years in medicine, sir, I'm Dr. Jagadis, sir. So after being 3 years in medicine at SSKM, sir, we see a huge volume of patients in the both outdoors as well as indoors. But the problem lies is the, sir, we do not have enough data. We do not keep the data of the patients that we are following, and yet we are following the foreign guidelines, which might or might not be applicable to our population that we cater to. So sometimes the onus is directly on the PGTs to keep the data, which is with all the academics and the work pressure, that it's very difficult to manage, sir, sometimes.
Absolutely.
And so we need a proper way of keeping the data in a very specific way, sir. So that it can be used for later purposes, so that even for machine learning, as we have seen, there's a beautiful paper that came out in Annals of Rheumatology, so this time, about chess, using chess as a baseline for artificial intelligence decision making. Sir, and sir, so they have, sir, because we do not keep the data, so that's a very big problem that we face from day-to-day life, sir.
Absolutely.
In my very short experience that I have faced, sir.
Absolutely. And example, I will tell you, I worked for a short while in rheumatology. I think I worked for 6 months in the UK in a good rheumatology center in between my endocrine jobs. And there, if a patient, I didn't see that many patients, but not hundreds, but a patient came with a chart or a file, as they call it, notes as they call it in the UK, which was about 6 inches thick. Now, if you saw 5 patients with this 6-inch thick data, and you went through that, you had the time and energy to go through that, you would learn more about rheumatology than if you saw 50 patients in an OPD setting, where you are just getting a cross-section, a snapshot. So if you see a 6-inch thick data on a patient, you see the patient in front of you, you see what happened to the patient, say 20 years ago, then, and progressively closer and closer to the present date when I was seeing the file. And you see how the patient changed, evolved over time. I think that was a huge learning experience. And it was an eye-opener for me when I came back to India, and I found that the rheumatologists of the day, and I'm not being patronizing, the rheumatologists of the day were in a lot of ways not as knowledgeable as I was in certain aspects, simply because I had seen the patient over time, at least in the records. Anyway, so the point is that this is very, very important. This is not appreciated. Records are thrown out. There is some privacy issues where they are saying that there's a law pending right now in India saying that records have to be thrown out because privacy is going to be violated if records are kept. So I think we have a long way to go before we can actually, meaningfully employ the vast amount of clinical data that we have at our disposal. And we have to, I think probably we'll have to learn the hard way. We haven't learned it yet, I'm sorry to say, and I agree with you on that.
So aren't there,
yes, exactly. Thank you.
So my question is, aren't there enough data scientists involved in the process of data cleaning and data processing and making the data reusable for the study for every organizations that are involved in medical services in India?
Actually, I can say from this from the government hospital point of view, actually the funds and the onus is actually, it's not much on the administration part is not really, it's more about treating the patient than about gathering the data regarding the patients. So that is something, and yeah, that's a big lesson. I would like sir to put a few words across about that. Yeah,
there's nothing you can do actually right now, because if you're a postgraduate involved in patient care, you look at the patient, look at the record you yourself are generating. You are going, you're going to the patient. There is a case sheet where we actually have to write physically. But what are you writing? So you're just putting the date and saying patient is okay, or just writing the blood pressure and saying patient is well. Now, if you're going to go to that data and to get some meaningful input out of that, it's not possible because you've not given detailed notes. And I'll just give an example of how detailed this is in the US. Example, before HIV was known to be a disease, there was, what happens with HIV, that you have initial illness and later on you get HIV per se. The initial illness was documented by residents who had no idea what they were dealing with. They just noted that the patients was a man having sex with man, and patient had certain problems which were noted in the file, and not by just one resident in one place, but by several people, because they're obsessive. They have to document. They documented everything that they saw. They didn't know what they were documenting. Later on, when people went back and they knew what was HIV, we are talking about the 80s, when they knew what it was, they found, yes, these residents had actually documented exactly what was happening without knowing what they were doing. And compare that with the type of documentation you have in our postgraduate institutes today. And from this sort of documentation, you're not going to get anything meaningful, I'm sorry to say. Just a bare minimum to satisfy certain regulatory requirements is all that is happening. So I think this shift in culture, and I'm not saying that the US was worse in the early 1900s. The US medical scene was far worse than what it was in India, maybe even 50 years ago. Much worse than what it is anytime. Anybody could give you any degree anywhere. Even if you sold snake oil, you could get a degree in medicine. But they cleaned up the system. And so it is something that, they are proud of. And I think there's a lot to be learned from that. Now, we are not in that situation at the moment. And I just gave the example of the type of data that we ourselves are generating at this point of time. So without the data, you have to use other people's data, or you have to grope in the dark. You have to reinvent the wheel again and again. That's all there is to be done. I'm sorry to say. So I think is that more or less, I think we've had an interesting discussion.
Yes, that was a great question, Niladji.
Excellent discussion. I think AI, medical research, AI is right now copy-paste of AI programs available in the West. And AI is not going to take off until there is as I said, a medical legal protection. Because as I said, telemedicine did not take off until there was a medical legal protection to telemedicine. And that only happened because of the pandemic. Otherwise, there would have been no telemedicine, legally approved telemedicine in India. Anyway, so I think this is just to, I would say, to stimulate, to make you think in ways that perhaps you have not had an opportunity to think. And I think I have enjoyed this interaction. And I must thank Arghya for waking up on a Sunday morning to babysit this program. And I think all power to him, and really, really congratulations to him, and of course to Paramita for getting this idea of getting it done. And thank you for everybody for all your questions and comments. And I would appreciate, you are most welcome if you wish to get my email and ask any other questions or other further questions you wish to ask, which you may not feel happy to do on this forum. So that's fine. Those are always open.
Thank you so much for your time, sir.
Thank you.
Thank you so much for your time.
Thank you. Thank you.
Thank you. Thank you.
Okay.
Thanks everyone for your interesting questions.